Wake up. It's the Sleep Unplugged podcast, episode 113, Upper Airway Resistance Syndrome. In the dark, I feel your resistance. Welcome, everyone, to the Sleep Unplugged podcast. My name is Chris Winter. I'm a neurologist, sleep specialist, and your host for this episode of the podcast. It's been another busy week. We had a good time talking about sleepwalking, lots of listener interaction with sleepwalking. I thought that would be a popular episode, and I posted on my webpage an interview I did with, I think it's Merritt Street Media, Dr. Phil's media company, the an interview about sleepwalking with a young woman who struggles with sleepwalking. So that's on there if you'd like to see it. I was in Baltimore. I want to thank all the wonderful people up in DC and the Baltimore area, particularly at Walter Reed Military Hospital, not Naval Hospital. So I made the mistake of saying go Navy when I was at the Walter Reed Hospital, and there was only one guy there. My good friend, Dr. Wormer, Ken Wormner, Wormner. God, I'm sorry. My nurse practitioner is Wormter. He's Ken Werner. That's right. Um, and Dr. Creamer and everybody up there, all the residents and fellows and good people working up there. Really want to thank you guys for the hospitality. Uh, Again, my name is Chris Whittem, I'm a neurologist and sleep specialist, your host. If you're new to the Sleep Unplugged podcast, welcome. If you're a veteran, welcome back. We generally start off with comments, corrections, criticisms. I wanted to just briefly touch upon, I've got a criticism, and my criticism is a judge, I believe in Chicago, was hosting a field trip for students. And during the field trip, one of the students in the court, just sitting in the gallery, watching the proceedings and learning how our judicial system works, I suppose, fell asleep. And the judge just kind of went off on her, ended up putting her in like a jail jumpsuit and handcuffing her. And later on saying, I was never going to put her in jail, but I wanted to, scare her, get her attention. And I'll just call your attention to episode 96, Narcolepsy Stories. My patience has reached its end. Man, this story would have fit very well in that episode. And I just want, again, just to put out there the idea that this young woman woke up. She didn't intend to hurt anybody, and she fell asleep in a courtroom. So rather than maybe pulling her aside after everything was done and saying, is everything okay on at home? Are you getting the sleep you need? Is this something that you do often? He humiliated her and probably really scared her. So I was thinking to myself, what if she has narcolepsy? What if she is working a job at night and trying to go to school to support her family? And I know I often make the comparison. What if she had had a seizure during the court proceeding? Would you have, while she was on the ground convulsing, put her in the jumpsuit and handcuffs for disrupting the order in your courtroom? Again, I just want everybody to kind of get that message that when it comes to sleepiness, we want to lead with questions, care, and compassion, and not contempt, anger, guilt, blame, punishment. It's been really upsetting to me to see that. So I'm glad I got that off my chest. Before we get going, you can contact me on social media, Dr. Chris Winter Twitter, Dr. Chris Winter Instagram. On my Instagram page, I follow Equinox hospitals and do some work for them. And a random person posted on the site that she was checking herself into the spa, which is amazing at the Equinox Hospital because it was her time of the month and that was her post. And I sent it to my daughter who produces the show and does a lot of work at Columbia doing menstrual research, and sent it to her and said, this is exactly what we were talking about in episode 108 when it comes to sleep, maybe giving yourself a little bit of a hall pass in the days, leading up to that point in your cycle. And I thought was really great that this person was saying, look, I'm going to treat myself when it's this time because it makes me feel a certain way. So I thought that was pretty great. So the question this week was, there's a brief one here from Jonathan. Jonathan said, "What is the world record for sleep deprivation? I can't figure that out." Um, they don't really keep that world record anymore, but the world record is Randy Gardner. It was a 17-year-old out at Stanford who was part of an experiment there with Bill Dement, who stayed awake 11 days and 24 minutes. Uh, Talking to Dr. Dement prior to his passing, he would often say Randy Gardner did not go 11 days and 24 minutes without sleep. It got to a point pretty quickly we couldn't keep him from having micro sleeps and but in terms of getting into bed and falling asleep for a long period of time, he didn't do it for 11, 24 days. Very difficult to keep him awake. He was hallucinating. He could not hold his attention. I think it was a pretty dramatic scene while he was doing that. So, anyway, we talk about, there's always a hidden musical lyric in our title. This week, the lyric "In the Dark, I Feel Your Resistance" is a Lana Del Rey lyric from her song Mariner's Apartment Complex. This was off of her sixth album, no offense, Norman fucking Rockwell, often abbreviated NFR, nominated for Album of the Year. I believe was it 2019? It seems a little bit far away, but ever since COVID, I have no perception of time. Somewhere in there, 2019, 2020, I think that she was nominated for that. Some people think it was sort of this answer, and we've talked about this a lot on the show, where an artist will write a song that kind of relates back to a song that somebody else written. We talked about Elvis Costello's uh, was a response to a song we did recently. I can't remember what it was. I'm kind of blanking on it. Um, but this was thought to be a response to the Leonard Cohen song Chelsea Hotel Number 2, which actually Lana Del Rey does perform. And in fact, one of the refrains in Lana Del Rey's song is "I'm your man, I'm your man," and that was the title of one of Leonard Cohen's um, finest albums, in my opinion, "I'm Your Man." So we'll put the Lana Del Rey, who happens to be my older son's one of his favorite artists. We'll put the Lana Del Rey song on our Sleep Unplugged Spotify playlist, Volume 3, and we'll move on with the discussion of upper airway resistance syndrome. For brevity, I'm going to call it UARS. And this really fits into the sleep apnea canon of episodes that we have done on this podcast, starting with episode 5, mild sleep apnea. We've talked about sleep apnea treatments and more severe sleep apnea in other episodes. Upper airway resistance could have been put into that category of mild sleep apnea, with the difference being individuals who've been diagnosed with upper airway resistance syndrome often are not diagnosed with sleep apnea. So let's refresh our memories a little bit in terms of how we diagnose and define sleep apnea. We generally think of sleep apnea as being an individual who has stopped breathing for 10 seconds or longer and dropped their oxygen by 3 or 4%, 5 times or more per hour throughout the night. So when you meet somebody and they tell you, "I have sleep apnea," you know automatically that they have more than 5 breathing problems per hour. And when they tell you, "I have named my CPAP and I go nowhere without it and it has changed my life," they're probably on the most likely on the higher side of breathing problems per hour. Again, if you're a listener of the show, you know my current record, and I will let every listener know when it's been broken. The current record that I have seen is 155 or so breathing problems per hour. Theoretical limit's 180. So we've talked about how amazing it can be to treat your sleep apnea. We've talked about sleep apnea surgeries and things that can be done. We've talked about oral appliances that you can use. And all those things are great for sleep apnea. So let's imagine a situation. So you know the criteria. You have to stop breathing for 10 seconds or longer, and your oxygen has to drop by a certain percent. So let's imagine a situation where an individual comes to the office We designate them as somebody who needs to have a sleep apnea, a sleep study, and they do, and they've got theoretically 1,000 breathing problems that happen during the night, but they're never more than 8 seconds. And when they have these smaller breathing disturbances, they tend to arouse from sleep. So you can imagine an individual stops breathing for 8 seconds, awakens from sleep to catch their breath, is aroused from sleep, falls immediately back to sleep, and does it over and over throughout the night. They're going to feel very tired the next day. They're going to have disturbed sleep quality. Unfortunately, we're not going to be able to diagnose them with sleep apnea, though, because they don't meet the criteria of what we have established as being sleep apnea. Is this a huge problem? No, because generally speaking, by the time people are really sort of engaged in their symptoms, are really struggling, feeling the effects of the sleep apnea, they are meeting the criteria that have been set out for individuals who have sleep apnea. Again, let's remind ourselves what sleep apnea is. It is a collapse of the upper airway. The upper airway narrows. It's restricting air from being able to move through the airway. And that failure to breathe is causing somebody to wake up and interrupt their sleep. So the upper airway resistance presents a problem because there is a population of people who have disturbed sleep because of breathing, but they don't meet the criteria for sleep apnea. And it's a bigger problem now with the advent and the proliferation of the home sleep study. So, if you're asking me how I feel about home sleep studies, I actually really like them. My job, and I feel like my purpose is to find as much sleep apnea as I can and treat it. And one of the big obstacles is the in-lab sleep study. It is expensive and it's kind of scary to some. It is a hurdle in terms of, oh, I've got to, you know, arrange at work and arrange for somebody to be with the kids, and I got to go into this lab and have wires taped all over me and all the things that they're going to do, and I just don't want to do it. So it's not an easy sell. Nobody wants to spend the night necessarily in a sleep lab. So being able to say, hey, look, you don't have to. You just pick this little device up on your way home from work. We'll show you how to use it. It's a piece of cake. Take it home, wear it, bring it back. Psh, you're done. And I think that the home sleep study is awesome for the individual in whom you already have a pretty high suspicion that they've got sleep apnea. Hey, Chris, I'm a bit overweight, weighing in about 250. I've really put on some weight over the last few years, and my wife is really concerned about my breathing. I actually wake up sometimes and feel like I can't breathe. I am exhausted during the day. Just started my second high blood pressure medication, and I've got two brothers. They both have sleep apnea, both on CPAPs. And when we go fishing together, they both tell me I need to get one. So here I am. Great. Home sleep study coming right up. So to me, the home sleep study is great. And I think that when they first really hit the scene, insurances really pushed them on us. They kind of took the choice between a home sleep study and an in-lab sleep study away from us. I feel like that pendulum is swinging back. I don't feel like I have a whole lot of difficulty getting an in-lab study approved by an insurance when I want to get one. I think they saw that most doctors were pretty decent at figuring out who should get what. Now, when the in-lab study is done, we have a much better sense of the complete nature of breathing and what's happening in terms of an arousal. So, an arousal is typically when somebody awakens from sleep, but's not awake long enough to have memory of it, which would be more typically called an awakening. I awoke 3 times last night to go to the bathroom. I remember doing that. But if you were actually to study my sleep, you would see that I would have a lot of arousals, awakenings from being asleep that are so brief that there's no real recollection or memory of them. So when we only look at hypopneas, when an individual is breathing, but not enough to keep their oxygen level from dropping, or apneas, when a person fully arrests their breathing. Both hypopneas and apneas are being scored throughout any sleep study, home sleep study or in-lab sleep study. And we typically combine those two things. How many full stop breathing problems did you have per hour, the apneas? How many times did you struggle to breathe to the point where your oxygen was dropping per hour? Combine those and we get something called an AHI. So if anybody's ever had a sleep study, go find it, pull it out of the drawer and look for your AHI. The AHI is exactly what we were talking about at the top of the show. How many breathing problems per hour did you have throughout the night? And if you have sleep apnea, that number is probably greater than 5. So were it just for the AHI, we would miss people who have shorter breathing disturbances, less intense breathing disturbances, but still cause awakenings or, more precisely, arousals throughout the night. So we do have a way to capture that as well too, which is the RDI. So if you're looking at your sleep study, you probably see that you have an AHI and there's a number. The RDI is on there as well too. So the RDI is based upon an arousal index, meaning that there is some sort of arousal from sleep that was precipitated by a breathing disturbance. So that provides sort of an alternative pathway to diagnose somebody with sleep apnea. Now, if somebody has 103 breathing problems per hour, that's their AHI, and their RDI is 120. It just doesn't matter. The numbers are high enough that the AHI is going to give us what we need. What happens when we have a AHI, an AHI that is lower than 5? Your AHI is a 3, but your RDI is a 13. That allows us to make a breathing disturbance diagnosis in an individual who may be having breathing disturbances, but they just don't quite reach the criteria for diagnosing sleep apnea. And that's awesome because there have been cases, I think, in every sleep professional's career where we have seen somebody meet the RDI criteria, but not the AHI criteria, and benefit from some sort of breathing disturbance treatment. And I've got stories, not a lot of them, but some stories. And I think that the real bottom line, if you could take away anything from this podcast, is everybody who walks in and eventually gets a sleep study has to some degree this sort of ethereal, imaginary pre-test probability. 300-pound truck driver, thick neck, loud snore, partner hears him stop breathing. He feels like he stops breathing, gasping for air, high blood pressure, overweight, like heart attack. Like as you start going through these things, the thick neck, the male gender, the weight, you're building a story that's making it more and more likely that that person has sleep apnea. And they're telling you, I know I got sleep apnea. Everybody says I've got it. I'm ready to treat it now. So when that individual comes back with a normal sleep study, which I'm going to tell you right now, they're not, you would question it. You might say, I wonder if the probes look good. I'm going to pull that sleep study up and really examine it. Like, really? Like, no breathing disturbances whatsoever? Was it misscored or, something fail in the test? Because I really believe this person was going to have sleep apnea. So that's an extreme example. Let's give another example of a younger patient, female, who is tired, not hypertensive, not overweight, tonsils, kind of big, and reports of some snoring from her partner, but not a tremendous amount. She says, yeah, she snores, but it's not that big of a deal. So you're going into the test thinking, you know, not sure what's going on here, but sleep apnea is not a done deal. If that's the case, you probably shouldn't be doing a home sleep study for a couple reasons. Number one, it's not as accurate as an in-lab study. Generally speaking, home sleep studies don't tend to overestimate the problem. They're pretty good at counting breathing disturbances. They're not great at determining sleep. So if a home sleep study says you have sleep apnea, you have it. If a home sleep study says you don't, you probably don't, but you could have some, a little bit. And I have seen home studies that have become in-lab studies later on. Like we've rechecked them. And I've seen somewhere at most a difference of about 15 to 20 breathing problems per hour. And that's extreme, meaning that the home sleep study said 4, the in-lab study said 19. So 4 was normal, 19 puts you in that mild sleep apnea category. So the other reason, besides the fact that home sleep studies are not quite as accurate because they don't really measure brain activity in sleep, has everything to do with that brain activity, meaning that that arousal index that we talked about that we use to calculate the RDI is fundamentally dependent upon our ability to define and see an arousal. And for many home studies, they're just not capable of doing that. So that RDI in a home sleep study may not be able to be calculated because you're only looking at breathing effort, air coming through the nose and mouth, and maybe a pulse oximeter. So without that electrical activity of the brain to define the arousal, it's very difficult sometimes with a home sleep study to calculate that RDI. You're really looking more at apopneas and apneas, or an AHI. So I want to say all this because one study actually found upper airway resistance or sleep apnea in about 56% of children with ADHD. So just think about that for a minute. Over half of patients with ADHD, kids, have either sleep apnea or upper airway resistance syndrome. So if it's that prevalent in children with ADHD, think about adults who are tired. If you're asking me, what is the number one diagnosis of individuals coming to the clinic who are tired, sleepy? It's sleep apnea every day of the week and twice on Sunday. It's an enormous number. So we have to be very careful because the pretest probability is so great in the adult population in this world that when we tell somebody they don't have it, or they don't have a breathing disturbance that's causing their excessive sleepiness, we want to be very sure about that. So if you are tired and you snore and people tell you that they think you have sleep apnea and you have had a sleep study, a home sleep study, a device you took home, and you went back to the doctor and they said, nope, you're normal, it's really important to understand that you may very well be normal, but you also could have very mild apnea that the home study didn't pick up or upper airway resistance syndrome. So, what do we do with upper airway resistance syndrome patients? Positional therapy, which we've talked about before with sleep apnea, can be very helpful, meaning we're talking about a mild airway disturbance here because we're not even meeting the criteria of sleep apnea. So just simply getting off of your back, eliminating alcohol before you go to bed, sleeping with your head slightly elevated could make a huge, huge difference. These are also the people in whom 5 to 10 pounds, that swing could make a big difference too. And they'll tell you, when I weighed 130, I slept better, and my partner says I didn't snore. It's been stressful lately with work and whatnot, and I'm now about 140, and I'm snoring more and not sleeping quite as well. I feel like I'll wake up more to go to the bathroom. I'm just generally more tired during the day. So could losing that 10 pounds make a difference? Absolutely. There are some medications that can be useful. We're talking about a very subtle increase in that airway resistance, so much so that it's not affecting oxygen levels. It's just kind of you can hear the increased resistance in that person's breathing. So, doing something to open up the nasal passages, we were talking about nasal strips, the little inserts in the nose, even nasal sprays. Just be careful with the over-the-counter ones. Those are things that you really shouldn't be using on a regular basis, but like an inhaled nasal steroid can be very helpful for people. We talked about oral appliances, devices you wear in the mouth that can advance the mandible, hold the tongue. They're doing something to either stabilize or open up the airway. So discussing things with a dentist could be helpful. However, it can be very difficult to get things paid for when it comes to oral appliances and snoring and sleep apnea. In the best of situations, upper airway resistance sometimes is something insurances are not going to play ball with. They want to see more than, say, 15 breathing problems per hour. Your patient has, an RDI of 9. So sometimes that can be kind of difficult too, but worth fighting for. There are devices that you can kind of do yourself, the Zipas and the Z Quiets you can find on Amazon, etc. Surgery could be a more extreme treatment, but certainly could be on the table. And that surgery can really run the gamut. CPAP is generally what we're looking at in terms of treatment, and probably doing that for a variety of reasons. We're on that cusp. If you go back to listen to episode 5, again, this is kind of that same algorithm as mild sleep apnea. You've got some trappings of sleep apnea. You've got, you've met the criteria for upper airway resistance syndrome. You snore, but there's not a lot of significant breathing disturbances. Let's try a CPAP. Let's see what happens. The CPAP is going to eliminate the resistance to the breathing. It's going to treat that problem pretty effectively generally. So when somebody comes back and says, "Yeah, I put the CPAP on and I feel pretty great," I think that's a slam dunk. I mean, if you're asking me, tell me, let's do a podcast episode about all the people who pretend to like a CPAP so they can get one. They can trick the system into getting a CPAP. Man, that's going to be one short episode because it doesn't happen. I think most people go into that arrangement, again, not really wanting it. They don't want the CPAP to work because no, it does work. It works really well. This person's awakened now, feeling like they've rested, feeling like they've felt great for the first time ever. So yeah, I think we need to believe people when the CPAPs work. So the bottom line here is that if you think you have sleep apnea and you've been tested and you're close, especially on a home sleep study, and you went home and you told your partner, I got it checked, and they said no, and your partner's like, what? You absolutely have sleep apnea. Don't stop pushing because there's an intermediate gray area of diagnosis that you could explore with your sleep specialist. Again, I'll tell you a story. A woman came to see me. We did a sleep study. Her AHI was 2. I believe her RDI was not much higher than that. She did not have sleep apnea. She did not have UARS that I could see. And she looked crestfallen when I told her that. She left. She came back and said, Chris, 6 months later, Chris, I know I have it. Can I just try a CPAP? Sure, of course you can. I'm not going to tell somebody no. There's no danger in trying a CPAP. Oh, I wore one for a month. I don't have sleep apnea. And it was interesting to see what it felt like. I kind of liked it in a strange way. So, another podcast. So she came back after trying it and said, oh, it's night and day. Now, do I have a lot of patients who fit that criteria? No. But all you need is one as a provider like me to sort of learn your lesson that these people are out there and we need to really, really look hard to find them. So that's it. Upper airway resistance syndrome. If you have any questions or experience with this, or if you were told you don't have sleep apnea, but you later on tried a CPAP and you had UARS or treated it some other way and found great success, I really want to hear about it. Dr. Chris Winter Twitter, Dr. Chris Winter Instagram. Again, I really appreciate the reviews of those of you who take the time to subscribe or write a review. Take a listen to Lana Del Rey on the Sleep Unplugged Spotify Volume 3 playlist. And until next week, sleep well.